I think yes, together.
Marking it strap.
Stay over here, we can see that.
You can see the scoreboard.
You should want to minimize the names every time.
Zoomers, can you hear me? And can you see the shared PowerPoint? People on Zoom.
Yes, we can hear it and see the PowerPoint.
Can you hear it? Previous.
And I am recording. I think it gives the Zoom people, I think it gives you guys a notification, but just in case it didn't, just letting you guys know and record this. So it's been a while since I've recorded one anyway, and but we can have this available to whoever wants it. But I will stop recording when we get to the game part. But the Zoomers, you can still stay on and participate, and we'll talk about how to do that. It's not the best for Zoom, but we will do our best. Okay, so quickly, we're gonna go through some of these slides. And Zoomers, if you have a question or want to say something, you could just speak through the microphone if you can. Sometimes with going through the PowerPoint and seeing your chat responses is a little bit difficult for me. So if you have an answer to a question, you can feel free to speak. All right, so we're gonna talk about skin complaints, just be able to describe, diagnose, and recommend evidence-based plans of care. And make sure you guys to remember that we don't have all those individual evaluations anymore. So if there's somebody stand out, please include that in that end of course evaluation. And let's see if I can. Somebody told me how to make this smaller and I don't remember.
High floating meeting control.
There you go. Okay, thank you very much. All right, so ABCs of voice and lesions. You guys have heard this a million times. How do I? All right, this is hiding everything too. So ABCDE, greater than 6 millimeters in particular, but if they're talking about anything that's growing or changing or irritating or bleeding, you guys have heard, like when they shave, I've literally had patients tell me that like I shave and it keeps coming back, or they like pick it off somewhere on their bodies and it keeps coming back. But at the bottom it says skin survey should be done at least yearly. By this. Okay. All right. So Rocky Mountain spotted fever, it can last for 2 to 3 weeks and lots of vague symptoms, right? But remember that it begins on the legs or arms, includes the soles of the feet or palms of the hands, and then spreads to the trunk, so spreads centrally. Not every case of Rocky Mountain spotted fever will have the rash, but they will have the fever, right? It's called Rocky Mountain spotted fever for a reason. So it doesn't tell you if the patient has a fever, then you don't need to select that. But it can be very tricky because symptoms can start any time 3 to 14 days after a tick bite. And remember, just asking what they've done in the last couple of weeks. If they live in areas that they have exposure. I have one patient that is a vet, and so they're pulling ticks off of things all the time, but considered high risk because they're just around them. But treatment is tetracyclines or doxy, and chloramphenicol is the only alternative to that. VZV or chicken pox. I was like to ask, have any of you guys had chicken pox? Two of you. Okay. Not the vaccine.
Both have shingles, right?
Oh my goodness.
Nasty.
Sheesh. Okay.
Can remind me.
Yeah. It's great.
I haven't seen my daughter.
Those things in the garden.
I'm waiting.
I never got it.
Nothing.
My little siblings. But yeah, that was all before they had vaccines. So, and probably we'll be seeing this a little bit more and more with the anti-vaccine efforts. So something to just be thinking about, recognizing. But the key thing with chickenpox, and this was the best picture, I think it's really good actually, but you can see all these varying stages of chickenpox. It's very classic, very different from lots of other rashes, where you can see, like here, this one looks different than this one. This one's still blistered up. This one's ulcerated and scabbed over. Really, there's not much to do besides supportive care. But if they are at high risk for complications, then you can do antiviral therapy to help reduce risks, such as valacyclovir or acyclovir. All right, so AKs, you see them everywhere, all the time. Sun exposed areas, so top of the scalp, will have many here. Rough, scaly, red macules on sun damaged skin. And then these, you can see some of these have these hyperkeratotic papules there. So these can turn into SCC, but the risk of it progressing is low. But the ones that do become SCCs have approximately 60% of them were the AKs. So it is worth trying to treat them as best as possible. Options would be curettage, excision, and cryotherapy. But of course, you're not going to do, like that guy's scalp, I'm not going to do cryo all over his scalp, right? That would be torturous. So that's something like 5FU or Methimod would be something that you would do for those larger areas, but you do have to warn them that the areas will often look more angry, worse, really red, maybe sensitive whenever it's doing that, because it's really cool actually with how it works and just targets those damaged areas. It's really pretty neat. So SKs, very common as well. It's the most common benign skin tumor in adults greater than 30. And they have this stuck-on appearance, greasy, wax-like are all key things that you'll see. A lot of time you'll find them on the trunks, but you can see them technically anywhere. Other things that people will call them are liver spots or age spots. People come in like, is this just an age spot or is this something I have to worry about? And one of the key things with derm in general, but especially with SKs, is asking if they have anything else that looks like that, right? And weirdly, they may have a bunch and then they just ask about one particular one. Maybe it's just more bothersome, things catch on it. But if it looks like 10 other ones, then probably not a problem. But of course, you have a low threshold to biopsy if needed. But so if it does look pretty different from the rest, go ahead and do that either way. Shingles. So remember, BCV can pop back up with these shingles and these dermatomes unilaterally. You do need to know these dermatomes for certain questions on your shelf. Okay. Basal cell carcinoma, pearly papules with telangiectasia, good for that many times. Or it can be this erythematous, slightly scaly patch here, but rolled edges with pearly gray borders. It can often have an ulceration like here. You can see all these telangiectasias coming off here. But you do want to get a full thickness biopsy at the edge of the lesion to send to pathology. Once you know that you have that confirmation, then you would send them to Mohs, right? Especially if they're large, aggressive, or in that H zone, and I have a slide of the H zone just in case you guys need to see that again. But be mindful of those areas. We're pretty good at most of us knowing like this needs to go somewhere else, if at least a derm. A lot of the time it's derm ends up sending to Mohs because me personally, like I do skin biopsies, but I'm not gonna even be biopsying this on somebody's face. That for me personally, I would be sending to dermatology, have them biopsy and then they send to Mo's. That is a very, very sensitive area. Let's see. So if there's some that are not in the H zone, then and let's say that they have lots of comorbidities, they can't tolerate Mohs surgery, then you could do other things like desiccation, curettage, or a Miclomod, but that's not the ideal treatment. All right, and so here is the H zone, the cosmetically critical areas. You're just going to be really careful. So again, like me personally, I don't biopsy things here or anywhere on these areas. That's a no-go for me. Some may be braver than I, but I will send them to Jen.
What is that zone like based on? Like,
Some of it is like lymphatic drainage, blood flow, where they even say, you know, like not to even pop pimples in those areas. I know a lot of people do, but you'll sometimes with things gone wrong, you can cause real bad swelling, backflow, and make yourself septic potentially with that. Acanthosis migricans. Again, you guys have seen this lots of times, but hyperpigmented thickening in the axilla, and then lots of skin tags visible here. We have people come in all the time. We see skin tags way more than the acanthosis. I don't know if you guys have seen it in real life or not. Hopefully you've seen at least one, but skin tags you will see way more. Billing wise, interesting. So we just had one on Friday. Yes. And so anyway, the resident was like, so they said they have a bunch more, like how many can we take off? Well, according to the billing code, it's less than 15. So you do 15 and they have charged a certain amount. I mean, there's some that will have well over 15 in just one armpit. She thankfully only had she had like one on her back and then a few under her on her armpit on one side and then nothing on the other side. But anyway, there's a little billing tidbit for you, up to 15. Animal bites. So with acute care, remember just like the basic things, right? Make sure it's not acutely bleeding and not infected. So you're going to try to irrigate it with normal saline. You know, if it initially at home, you know, they're going to wash out of the sink on their way to the ER potentially. But irrigation with normal saline if they're at the hospital or in your clinic. Determine if they're needing wound closure and antibiotics / if they need rabies or tetanus or potentially anything else. Preferred antibiotic agents is going to be the amoxicillin clavulanate. If it's complicated, you're going to give them something through the IV. So things that complicate it, if they come in and sometimes people wait several days, of course, you know, they go, I have this bite and now my entire arm is red. Like, oh, great. So they need to go straight to the ER, right? Or be directly admitted, either way. So if you see that, then you're going to say they have cellulitis with a rapidly spreading infection. You're going to start them on IV antibiotics, rule them out for sepsis, especially so if they come in with a bite, but it doesn't look like cellulitis, they have fever, that would also be complicated. But more than likely, you're going to send them to the ER, or they'll present to the ER if whatever happened was bad enough, their skin's hanging open. They're going to start them on the antibiotics, give them their rabies and tetanus and all that, and then draw labs, blood cultures, make sure that they're not septic from all of that. Also, depending on the injury, you may or may not need to rule out osteomyelitis. I had a guy that a couple of months ago where he had he has 2 pit bulls and I guess a piece of meat dropped on the floor and the dogs were fighting and he was trying to keep them from fighting each other and then ripped his hand because he stuck his hand down in the middle of it all. Thankfully, he did not have muscle or tendon injury, but it was very close. So those are all the things you do. Make sure that you do your nerve checks, make sure that they have normal grip strength, normal blood flow, etc. Make sure that they don't need a surgical consult as well. Okay, so psoriasis, very well demarcated. It's a pretty neat one where you can see this not very often other times. You know, if it wasn't all scaly, it was just the red, then it'd be something like a cellulitis where it is pretty well demarcated. But often with the erythematous plaque and coarse scale. Scabies, I included this one on here because this one does stump a lot of people in real life. I've had, so you guys know, like with the classic scabies that they have it like between the webs of the fingers, like in this picture, and then here across the wrists. And they're described as multiple small erythematous papules, often excoriated. And you can confirm with detection of these things with microscopic examination, but most of the time you're just going to clinically treat them. I've never personally seen anybody do scrapings for this, but in theory you can. And maybe you guys did some ones in undergrad, I don't know, but in clinically I haven't seen it. When I did extra rotations with derm too, but so this in babies we don't really think of. Actually just saw a new post about this today with somebody asking and they answer. So I'm in like physician mom groups with Facebook, and they come in handy all the time, and it's wonderful. It's like my free consults for everybody, and I get like so much CME just learning from everybody and all of us love it that way. But somebody had posted a picture that looks almost exactly like this, and I saw a case like this many years ago, where this kiddo had been treated. He was probably 4 months by the time he saw me. And he'd been treated for eczema 2 different times. Once before, you know, like just like the topical steroids, and then again, basically telling the family, somebody else had told them again, like, make sure you're not bathing the baby too much, you know, pat to dry and put on this steroid cream, and then you rub all this aquaphor on, and it was not any better. It was actually worse. And that is very unusual. I mean, eczema usually will respond somewhat. And so anyway, I ended up, I saw them that when they were seen the 3rd time, they see me for the first time. And I treated them for scabies, but it's interesting because like this post that I saw was saying the same thing, where like nobody else in the house had anything like this. And it's considered to be very highly contagious. So you would think that somebody else would, but in newborns, you can see it isolated within a household. And I don't know if it's their immune system or what it is necessarily, but if you see this, it could be scabies and not. All right, so polymorphic eruption of pregnancy, PEP, or used to be PUP, gravid abdomen with striae, and so like within these stretch marks, you'll see these papules, erythematous papules. They're usually very itchy, but it's not something that you have to necessarily worry about. It's not contagious, and it will go away after they deliver. So hopefully it's closer to the end of delivery when they present with this. But they can be pretty miserable from the symptoms of it. Okay. Oh, pages like that. That's okay. So, do you guys how do you guys want to break up the way that you already are?
This works.
Works. Okay, I do need a volunteer for that board to keep track of points for the renal, and then I need. Sorry, I need another one.
You don't wanna be on the same team with Drake?
We done it though.
And then I'll.
I'm just saying these are now.
Buzzing.
I don't have any off, so we'll just do buzzing.
Yeah.
Whenever we use them.
I'm just gonna buzz.
You know, Mary, you're the.
I'm like, fuck you.
Fuck you. I did not know there.
I
said it. Oh, you said I have? Oh, I do have.
Oh, I think you said I have to carry.
Yeah, you have.
No, yeah, but you thought like you looked at me, you're like, oh my, I'm gonna have to carry. Like, that's what sounds scary. I honestly, Durham's honestly my weakest round. Yeah, like step, bro. I was so
I don't know ball.
like I could tell Baze was so bad on if so, then I could like I could never tell Baze on Swamus hard. If it wasn't like Vitello playing Deja or like.
I guess I'll just.
And we locked in.
That's good. That's good.
Oh, I need to stop.
Sorry, we got.
Yeah, I was at the game.
Dude, oh, that was crazy. I was